Welcome to Pathagonia. This is Jay. Today we are going to talk about bone tumors using Kurt's notes. I'm currently on my soft tissue and bone rotation, and there are so many entities to learn. So I'm grateful to have a good framework brought to you by Kurt's notes. So let's get to it. Normal bone. You can divide it based on bone organization into two parts: woven bone, immature, and lamellar bone, mature. Woven bones are the collagen fibers are haphazardly arranged, as you can see here. They're formed during ossification and rapid bone growth and repair. They're relatively hypercellular with large cells when you compare them with your lamellar bone, which is mature bone. These are collagen fibers organized in parallel arrays. There is formation through gradual remodeling of woven bone. In adults, almost all bone is lamellar, and relative to the woven bone, lamellar bone will be hypocellular with small cells. Now, within lamellar mature bone, you can have two types of architecture: the cortical bone or compact bone. This is dense lamellar bone with Haversian canals. Remind you of MS1, anyone? Surrounded by concentric lamellar units. And then you have trabecular bone or cancellous bone. These are connecting plates of lamellar bone. So tumor bone is typically immature or woven bone, and it can be mineralized or unmineralized. If it's unmineralized, it's called osteoid. And then if you do see that, you want to think of osteosarcoma. And sometimes it can be hard to differentiate osteoid from other collagens or extracellular material. And your hints are these cement lines, which are thin, dark, linear lines that are seen in osteoid, but not other substances. And your SAPB2, though positivity is because of osteoblastic differentiation. And it can be positive in osteosarcoma, especially if you have the osteoblastic variant of osteosarcoma. Epidemiology: the primary clinically significant bone tumors are rare. However, the insignificant but the benign tumors like non-ossifying fibromas are relatively common. So primary bone sarcomas have a bimodal distribution. The first peak is in the second decades because these are teens that are actively growing, and you can get osteosarcoma or Ewing sarcoma, and then it can be after age 60 where you can get your chondrosarcoma and osteosarcoma. Although the tumors varies in location, the most common location is near the knee. And why is that? Because it has the fastest growing growth plate. And then bone tumors like osteosarcomas can arise de novo most oftentimes, but you can have secondary osteosarcomas due to radiation, Paget's disease, chronic osteomyelitis, bone infarcts, and prosthesis. And clinically, the patient will come to their clinician with pain that's classically worse at night, and you can have pathologic fractures. So, you know how radiology and pathology are I think of them as shake and bake. This is much more pertinent in bone and soft tissue because imaging is so helpful in your differentials. So you can divide your differential bone tumors based on whether they're younger than 30 or older than 30, and also by the location of the bone: diaphysis, metaphysis, and epiphysis. In the diaphysis, for those under 30, you can have fibrous dysplasia, Ewing's, Langerhans cell histiocytosis, leukemia. You can have your osteoid osteoma, the non-ossifying fibroma, one of the most common benign bone tumors. Aneurysmal bone cysts. As we go across to the metaphysis, you can get enchondroma, simple cysts, osteochondromas, osteosarcomas, and then in epiphysis, you can get infection and chondroblastoma. And you can see this growth plate here. In adults, that growth plate is more or less closed. And in the diaphysis, you can get metastasis, myeloma, lymphoma. In the metaphysis, you can get enchondroma, chondrosarcoma. In the epiphysis, you can get infection and giant cell tumor bone. So just put these in your Anki cards if you do Anki. These are classic locations. So anterior cortex of tibia, that's Your differentials include adamantinoma and osteofibrous dysplasia. Your posterior cortex of distal femur, that's going to be your osteosarcoma. Your clivus, vertebral bodies, and sacrum, you'll see a chordoma. You'll have those phycoliferous cells that basically means have a foamy-like cytoplasm. And then the posterior elements of spine is your osteoblastoma. All right, let's go to osteogenic tumors, meaning tumors generating neoplastic bone. Osteoid, osteoma. We talked about osteoid, right? Kind of woven bone that's not mineralized. Well, this is not necessarily osteosarcoma, even though it does have osteoid. It's benign. It's often in the cortex of your long bones. It's less than or equal to 2 centimeters with the central nidus composed of microtrabecular woven bone rimmed by plump, bland osteoblasts and vascularized stroma. It's often surrounded by sclerosis with circumscribed, abrupt transition to normal bone at the edge of the nidus. There should not be nuclear pleomorphism nor any cartilage, and it has a FOS gene rearrangement. Osteoblastoma. This is also benign. Remember, in terms of classic locations, this is in the posterior spine, particularly the neural arch. It looks similar to osteoid osteoma with delicate woven bone rimmed by a layer of plump osteoblasts, as you can see here. And on a side note, osteoblasts on cyto, they can look plasmacytoid, and they can be particularly confusing if you're suspecting the patient has multiple myeloma or plasma cell myeloma and you sample osteoblasts. Osteoblastomas have growth potential, and generally are greater than or equal to 2 centimeters, in contrast to your osteoid osteoma. They also have FOS gene rearrangement, and they are well circumscribed without destructive invasion of bone. If you do see infiltration, consider osteosarcoma, more specifically your osteoblastoma-like. Osteoma. These are usually on the face or jaw. They're often on the surface, and they're composed of lamellar or cortical type bone. This is why these cells are hypocellular, or it's hypocellular. And when it develops in the medullary cavity, we use the term bone island. If you see multiple osteomas, think of your syndrome of Gardner syndrome, a subset of familial adenomatous polyposis, which is due to a 5q21 deletion or mutation, and generally require no treatment unless it's symptomatic. All right, let's go to our cancers. Conventional osteosarcoma. This is a high-grade sarcoma in which the tumor cells produce bone. It's the most common primary bone sarcoma, and location-wise involves the metaphysis of long bones near the knee. And then imaging, you'll see a Codman's triangle, and that's like a sunburst-like production of new bone that's from a periosteal response from cortical disruption by the tumor. So there's a lot of histologic spectrums as alluded to, such as your chondroblastic type, your osteoblastic type. You can get like a sclerosing, fibrosing type. But the main common denominator is for osteosarcoma in general, you need neoplastic bone formation, such as osteoid, and any amount is sufficient. So this is why it can be hard on biopsies, especially if you don't sample that portion of neoplastic bone. Architecturally, osteosarcoma will have the tumor intimately associated with the regular bone, and it's woven with disorganized trabeculi. They'll have infiltrative growth where it replaces the marrow space and erodes pre-existing bone, and hence the kind of stepwise reaction to the Codman's triangle. And it often has high-grade cytologic atypia, as you can see here. It's important to note that they do normalize or become less pleomorphic when they are surrounded by bone matrix. You can often see atypical mites. And IHCs, SATB2 can help identify the osteoblasts, and it will be more helpful if it's osteoblastic osteosarcoma. Frequently expressed as EMA, cytokeratin, CD99, S100, and actins. Molecularly, it can be very complex chromosomal structure or instability, but they can also have frequent TP53 and retinoblastoma 1 mutations, and that's why osteosarcoma is a risk in those with Li-Fraumeni and hereditary retinoblastoma. And sometimes you can have an MDM2 amplification because this arises especially if high-grade central osteosarcoma arises from prior low-grade central osteosarcoma. We'll learn that low-grade central osteosarcoma has that MDM2 amplification, just like your atypical lipomatous tumor / well-differentiated liposarcoma. Okay, so how do we treat these osteosarcomas? First, they're going to be diagnosed by biopsy and imaging. Then they'll be treated with neoadjuvant chemo. Then there'll be a resection followed by post-operative chemo. And one way to determine prognosis is your histologic response to neoadjuvant. In that resection specimen, you want to sample carefully to see if the response is greater than 90% necrosis. Low-grade central osteosarcoma, we mentioned this is has an MDM2 amplification. It has good prognosis if widely resected, but can dedifferentiate into high-grade osteosarcoma. This arises in the intramedullary cavity, most often in the metaphysis of long bones at the knee. You'll see moderately cellular fascicles of spindle cells with mild nuclear atypia with admixed, usually woven neoplastic bone, which is composed of long and thick bony trabeculae, often in parallel arrangements, and it can permeate the host bone. Telangiectatic osteosarcoma, your biggest differential you want to have is aneurysmal bone cyst. It has blood-filled or empty cystic spaces. It's separated by fibrous septae of variable thickness, and it's got to have these pleomorphic cells with significant nuclear atypia. You can see frequent atypical mites and often infiltrative. And then this is why it's hard, because if you only get a biopsy and you don't sample the osteoid and you don't sample for some reason the atypical cells, your differential includes that aneurysmal bone cyst. So you got to be really careful if you're thinking ABC to rule telangiectatic osteosarcoma out. Okay, par osteosarcoma. Remember, the classic location is the posterior metaphysis of the distal femur. It's going to be an exophytic lobular mass on the bone surface. It's a low-grade spindle cell tumor with woven bone formation. It's often hypocellular with minimal atypia and mitoses. Bone is often arranged in parallel, plus or minus osteoblastic rimming, and approximately 1/2 do contain cartilage. Just like your low-grade osteosarcoma, your par osteosarcoma has the MDM2 amplifications. It has excellent prognosis, although it can dedifferentiate. We talked about low-grade, high-grade central osteosarcoma. We talked about par osteosarcoma. Let's talk about peri-osteosarcoma. So these are malignant, predominantly chondroplastic, intermediate grade bone forming sarcoma arising from the bone surface, usually under the periosteum. It's often the diaphysis of long bones, especially the femur and tibia. And most of the tumor is composed of irregular lobules of cartilage with cytologic atypia. You can see intervening bands of primitive sarcoma that can show bone formation. It's better prognosis than conventional osteosarcoma, but less so compared to your par osteosarcoma. Personally, the way I like to think of it is par osteo is on the bone surface. It's the furthest away from the center of the bone. Then you have your periosteosarcoma, because this is under the periosteum. And then the closest to the center is your low-grade central and high-grade central osteosarcoma. Okay, let's talk about other variants of osteosarcoma, including your small cell osteosarcoma. It kind of fits into your small round blue cell differential. Also, your other differential is lymphoma. And then you can have, although rare, high-grade surface osteosarcoma. It basically looks like high-grade osteosarcoma, but instead arising in the center of the bone, it arises on the surface of the bone. Okay, let's talk about chondroblastic tumors, or tumors with cartilage production. Of note, Dr. Schaberg reminds us that S100, in addition to staining neural elements, adipocytic elements, cartilage stains with S100. Let's talk about a benign entity, a couple of entities, osteochondroma. This has a cartilage cap, as you can see here, with growth plate-like architecture. They have an underlying stalk with medullary and cortical bone, and it's continuous with the medullary cavity and the cortex of bone. You shouldn't see any significant nuclear atypia nor mitotic activity, and often on the metaphysis of long bones near the knee, and you'll have a biallelic inactivation of EXT1 or EXT2. Enchondroma, or I like to think of it as inchondroma. This is a hyaline cartilage neoplasm arising within the medullary cavity. It's oftentimes found in the short tubular bones of the hands. You won't see significant cytologic atypia, mites, or cortical invasion. However, you want to give some leniency of enchondromas in the hand, and if they have enchondromatosis, because these tumors can have increased cellularity, myxoid cartilage, mild atypia, and binukes. The way I like to think of it, as it kind of reminds me of in derm land, how you can have nevi and special site nevi, and you just give a higher degree, you get a higher degree of suspicion in the special site nevi, even though they're benign. Enchondromas will have a frequent IDH1 and IDH2 mutations. And then when you see an enchondroma in a patient who has multiple of these, you want to think about your Allié's disease and Maffucci syndrome. Talk about the Nora lesion, or the bizarre par osteochondromatous proliferation. Now say that 20 times on one foot doing jump ropes. No, I'm just kidding. So this is a benign surface lesion composed of spindled cells, cartilage, and bone. And it's most common in the small bones of the hand and feet, often the phalanges, and it's not contiguous with your medullary cavity. It's surrounded by cartilaginous cap with central trabecular bone via endochondral ossification. And between the cartilage and the bone, you'll see characteristic blue bone with basophilia. And the chondrocytes can show moderate atypia. Synoviochondromatosis. This is locally aggressive and involving the large joints, most commonly the knee. Histologically, you'll see multiple hyaline cartilage nodules within the synovium or loose in the joint space. The chondrocytes will cluster together in groups, and there's minimal atypia. Molecularly, it's defined by an FN1 ACV R2A fusion. And if there's significant atypia, such as loss of chondrocyte clustering, bone invasion, lots of mites, atypical mites, you want to think about malignancy. A malignant synoviochondromatosis. Okay, chondromyxoid fibroma. I hope y'all are hanging with me. We're doing good. So chondromyxoid fibroma, this is benign. It occurs in many sites, but often the long bones near the knee. It's going to be seen as lobulated lesions with sharp margins and zonal architecture. You'll see chondroid and stellate cells embedded in a chondroid to myxoid matrix in the center of each lobule. In the peripheral area, you'll see spindle cells and admixed giant cells. IHC, you'll have diffuse S100 positivity, like all cartilage, and molecularly, you'll have a GRM1 fusion upregulation. Chondroblastoma. This is benign. It involves the epiphysis of long bones, most commonly the femur. I got this once on my quiz, and fortunately I got it wrong at that time, but now I won't. You'll have sheets of ovoid to polygonal cells with a single grooved nucleus, and eosinophilic cytoplasm, and interspersed multinucleated giant cells, as you can see here. But the most IPR, instant pattern recognition, that you want to look out for is this chicken wire-like calcifications you see here. You can have islands of eosinophilic chondroid matrix, and molecularly it's associated with an H3.3 K36M substitution. It's similar to that molecular association with giant cell tumor of bone, and it's going to stain positive for S100 and DOG1. Subungual exostosis. This is a benign osteocartilaginous surface lesion in the distal pharyngeal bone underneath the nail bed, and it's most often the big toe and often in young adults. Sometimes the cartilage is mildly atypical with mites, but there is no continuity with medullary cavity in contrast to osteochondromas. All right, let's talk about chondrosarcomas. You can have 3 grades: grade 1, grade 2, grade 3. You can have central primary, you can have central secondary, and secondary peripheral. And you can have different types of chondrosarcoma. So let's get into it. So grade 1 chondrosarcoma can, based on location, be considered an atypical cartilaginous tumor. If it's in the appendicular skeleton, like your arm, your leg, you want to call it an atypical cartilaginous tumor because it's easier to resect and treat. If it's in the axial skeleton, you will call it chondrosarcoma grade 1 because it's harder to resect. It's analogous to when you have a atypical lipomatous tumor in the extremities, but if it's in the retroperitoneum, you'll call it a well-differentiated liposarcoma. So chondrosarcomas will have, the grade 1s will have abundant cartilaginous matrix, usually hyaline, but sometimes partially myxoid. They'll have this lobular growth and entrapment of pre-existing bone. You'll have increased cellularity, but the cytology should be bland. You can have common binucleated cells, but no significant nuclear atypia nor mitotic activity. But on low power, just look for that cartilage entrapping pre-existing bone. Okay, chondrosarcoma grade 2 and grade 3. So these both are malignant with metastatic potential. You'll see the same findings of cartilage entrapping existing bone, but they'll have increased cellularity and increased atypia, increased mites, as you can see below. There should be no osteoid production. Otherwise, you want to think about a chondroblastic osteosarcoma. Grade 1 and 2 associated with IDH1 or 2 mutations, and remember, your enchondromas is associated with IDH1 or 2, so it suggests it likely progressed from an enchondroma. Higher grade tumors, your grade 3s, may also have TP53, retinoblastoma 1, and CDKN2A mutations. So central chondrosarcoma arises in the medulla of a bone. Central primary is there's no existing precursor. Central secondary is it's arising from an enchondroma. And secondary peripheral is it arises in the pre-existing cartilaginous cap of an osteochondroma. Radiographically, the lobulations in a chondrosarcoma can look like popcorn calcifications. So let's talk about the different types of chondrosarcomas. You can have your dedifferentiated chondrosarcoma. Here is your chondrosarcoma, your traditional chondrosarcoma to your right, with an abrupt transition to a high-grade non-cartilaginous sarcoma. Your demographics include the femur of the elderly, and they have complex karyotypes with frequent IDH1 and 2 and TP53 mutations, and has a very poor prognosis. Mesenchymal chondrosarcoma. This is a biphasic tumor. The first portion, you'll have islands of organized hyaline cartilage. And then you'll have undifferentiated components with high NC ratios. That kind of gives you that vibe of small round blue cell tumor. And you can have frequent staghorn vessels, varied locations, but often presents craniofacially and defined by a HEY1 NCOA2 fusion. and has aggressive behavior. Clear cell chondrosarcoma, as implied by its name, it has clear cells with abundant cytoplasms. The nuclei will be centrally placed with distinct cell membranes. You'll have woven bone and osteoclast-like giant cells. You should see minimal atypia and low mitotic activity. Half of cases have a conventional low-grade chondrosarcoma component. And it's frequently in the epiphysis, particularly the femoral head. There's strong S100 in the clear cells and low-grade malignant. And remember how we talked about osteosarcoma? It can be periosteal. Well, you can have a periosteal chondrosarcoma, which is a cartilaginous tumor arising on the surface of a bone in close association with the periosteum, with either invasion of the underlying bone or greater than 5 centimeters. Oftentimes, they are located on the surface of long tubular bones, usually the distal femur. They comparatively have a low IDH1 and 2 mutation rate, as well as a low metastatic rate. And then there's also an entity called periosteal chondroma. And this is a well-marginated, lobulated cartilaginous tumor arising on the bone surface with elevation of the periosteum and erosion, but however, no invasion of the underlying bone cortex. So that's the main difference between periosteal chondroma and periosteal chondrosarcoma. You can have low to moderate cellularity and relatively uniform chondrocytes that'll usually the tumor will be less than 5 centimeters. All right, let's just do a brief recap. I know this is a longer one, so if you're with me at this stage, props to you. We're almost there. Let's do it. But just to kind of, because repetition is the key to adult learning, osteogenic tumors, we talked about osteoid osteoma. It's less than 2 centimeters. They have some kind of microtrabecular bone and has plump, bland osteoblasts. Osteoblastoma, you'll have in the posterior location of your spine, often greater than 2 centimeters. Both osteoblastoma and osteoid osteoma have FOS gene rearrangements. Osteomas can be associated with Gardner syndrome. Conventional osteosarcoma, you can have your high-grade central osteosarcoma. You can have your low-grade central osteosarcoma. This will have the MDM2 amplification, not high-grade, unless it's de-differentiated from your low-grade. You can have your telangiectatic osteosarcoma. You want to think about your differential of aneurysmal bone cyst. You can have your parosteal osteosarcoma. This is also an MDM2 amplification, and it's has excellent prognosis. And then you have your periosteal osteosarcoma. In between, the way I like to think of it, your parosteal and central is your periosteal, both in prognosis and location. And then you can have small cell osteosarcoma, high-grade surface osteosarcoma. Then we talked about chondroblastic tumors, including osteochondroma, enchondroma, usually in the short tubular bones of the hands, in the medullary cavity. It has IDH1, IDH2 mutations, and if you have multiple, you want to think about Allier disease and Maffucci. Your bizarre your bizarre parosteal osteochondromatous proliferation. You can see that blue bone with basophilia. It's also in the small bones of the hand and feet, not contiguous with your medullary cavity. You can have synovial chondromatosis. You'll see these multiple hyaline cartilage nodules within synovium or loosened joint space. They have a chance of becoming malignant. Chondromyxoid fibroma, often in the long bones near the knee. You'll have chondroid and stellate cells embedded in a chondroid to myxoid matrix. Chondroblastoma, usually in the epiphysis of long bones, most commonly the femur. Look for that chicken wire-like calcifications. You can have multinucleated giant cells, and it has the H3.3 K36M substitution like your giant cell tumor of bone. Subungual exostosis. It's an osteocartilaginous surface lesion in the distal pharyngeal bone underneath the nail bed, often the big toe. Chondrosarcoma, if it's in the arms or legs, you want to call it atypical cartilaginous tumor if it's well differentiated, or grade 1. And then if it's in the axial skeleton, you want to call it chondrosarcoma grade 1. Chondrosarcoma grade 2 and 3. We talk about dedifferentiated chondrosarcoma, mesenchymal chondrosarcoma, that biphasic HA1 NCOA2 fusion, clear cell chondrosarcoma, periosteal chondrosarcoma, defined with the invasion of the underlying bone or size greater than 5 centimeters. Otherwise, it's a periosteal chondroma. All right, let's go to hematopoietic neoplasms. You can have plasma cell neoplasms. If you do an IHC flow, it'll be CD138 positive, have monotypic IG light chain expression. If solitary, it's a solitary plasmacytoma. If systemic, with CRAB symptoms, hypercalcemia, renal insufficiency, anemia, bone involvement, plasma cell myeloma. Leukemia and lymphoma is always a consideration with cellular tumors that look small, round, and blue with scant cytoplasm. It can be primary to the bone, or it has bone involvement by a systemic process. If you are concerned, consider sending for flow. And you want to consider at least CD45, TDT and or CD34 for lymphoblastic leukemias, and CD138 for plasmacytoid. Langerhans cell histiocytosis, you'll have your characteristic grooved or folded nuclei, moderate amounts of eosinophilic cytoplasm, lots of associated eosinophils, as well as histiocytes and giant cells. You won't see prominent nucleoli or significant atypia, but your main bet to really cinch this diagnosis is your IHC and molecular. You'll see S100, but more specifically CD1A and Langerin. Molecularly, you can have a BRAF V600E, part of the MAPK pathway. If single, it often impacts the skull, and if multi, it can impact many bones and organs. Erdheim-Chester disease. So I guess before we begin with Erdheim-Chester, I just wanted to point out that your Langerhans cell histiocytosis, your Erdheim-Chester, and your Rosai-Dorfman, those are your histiocytic differentials. So for Erdheim-Chester, this is a clonal systemic histiocytosis with inflammation and fibrosis. You'll see foamy lipid-laden histiocytes with variable amounts of Tudin giant cells, small lymphocytes, and other inflammatory cells. There is, more often than not, fibrosis, which can be extensive. Usually involves the long bones, but there can be multi-systemic disease. The foamy histiocytes will stain with CD68, 163, and CD14. And molecularly, it can also has activations of the MAPK pathway, including your BRAF. Rosai-Dorfman is a histiocytic proliferation. It has large S100 positive histiocytes with peripoiesis, meaning the cells kind of go into another cell without getting phagocytosed. Otherwise, there would be phagocytosis. Cells have abundant eosinophilic to foamy cytoplasm. You can see associated fibrosis and inflammatory cells. And it will be positive for S100, but negative for CD1A and Langerin, and has good prognosis. Osteoclastic giant rich cell tumors. So these have their own differential as well, including your non-ossifying fibroma. These are very common. These are benign, however. You'll see histologically storiform proliferation of plump spindled cells with intermingled giant cells. There are scattered hemosiderophages and foamy macrophages. For skeletally immature patients, it's in the cortex of the metaphysis and long bones, often near the knee. And you can have a KRAS or FGFR mutations. Aneurysmal bone cysts. These are benign. They're multiloculated blood-filled cystic spaces, and the wall of the cyst has fibroblasts, osteoclast-like giant cells, hemosiderin pigment, and new bone formation. It's most oftentimes seen in the metaphysis of long bones and posterior vertebrae, most common in kids. And if you're unsure if this is aneurysmal bone cyst or telangiectatic osteosarcoma, you could get a molecular, and ABCs should show you a USP6 gene arrangement, which is of note, same as nodular fasciitis. Giant cell tumor of bone. You'll have these reactive large osteoclasts together with a mononuclear neoplastic component without atypia. So these giant cells can have more than 50 nuclei, and it's important to know that the tumor cells are the cells kind of in between the giant cells. These are generally in skeletally mature individuals, older individuals involving the epiphysis. And molecularly, it's going to have an H3.3 gene mutation. And chondroblastoma has similar mutations. And it can be treated with denosumab, which is a rank ligand inhibitor. And the giant cells will disappear, and bland spindle cells with new bone deposition. And then you can have a malignant giant cell tumor of the bone, which is uncommon. Also, some other entities include chondroblastomas, some osteosarcomas, and Paget's disease. Okay, fibrogenic tumors. You can have your desmoplastic fibroma. This is locally aggressive, infiltrative looking desmoid type fibromatosis. It's all goes around the same direction. You'll have variable SMA, and you'll have your nuclear beta-catenin in a subset, and most common in a mandible of children. And you have to exclude low-grade central osteosarcoma and fibrous dysplasia. A fibrosarcoma is malignant. It's a diagnosis of exclusion. You'll have monomorphic spindle cell proliferation with fascicular architecture. It lacks your morphologic, IHC, and genetic features suggestive of an alternative diagnosis. And it's got the herringbone pattern. Vascular lesions. These are tumors showing vascular or endothelial differentiation. And if you're unsure, you can get endothelial markers including ERG, CD31, CD34, FLI1, factor 8, and these include your hemangioma. It's a benign tumor with small or large caliber thin-walled blood vessels, and it's a single layer of non-atypical endothelial cells, and most common in the vertebral bodies. And just before we go on to the next one, epithelioid hemangioma, it's important to know the most important thing I've been told by my staff is looking at low power, see if it's circumscribed or not. More often than not, your benign entities will be well circumscribed. Epithelioid hemangioma is a locally aggressive vascular neoplasm. It's large epithelioid endothelial cells with densely eosinophilic cytoplasm. It has distinct vasoformation, lobular architecture. It can have solid areas. Mitoses are infrequent and not atypical. They often have background inflammatory infiltrate, most notably eosinophils, and most common in the long bones, and will be positive for vascular markers because it's epithelioid, keratins, EMA, plus or minus FOS. Molecular, you can see rearrangements of FOS or FOSB. Epithelioid hemangioendothelioma. This is a low to intermediate grade malignancy. You'll see your prototypical kind of blister cells, and you'll see cords and nests of epithelioid endothelial cells within the myxohyalin stroma. There's no lobular architecture, and large cells with abundant eosinophilic cytoplasm, and some of them have intracytoplasmic lumina with red blood cells. It'll stain positive not only for vascular markers, but your keratins, EMA, CAMTA1, and molecularly, most of them are WWTR1, CAMTA1 fusion, or YAP1 TFE3 fusion. Kind of sounds like a URL link, just as an aside, www.tr1, camta1.com. Angiosarcoma. This is high-grade malignant neoplasm with endothelial differentiation. It has vasoformative architecture and or expression of endothelial markers. You'll see atypical endothelial cells. You can see numerous extravasated red blood cells, and they'll have, your key thing is nuclear atypia and mites. And if you're thinking about angiosarcoma, you might consider getting an HHV8 to rule out capaces, especially if the patient is immunocompromised or immunosuppressed. And then just for angiosarcomas, there's basically 3 types of angiosarcomas, the way I'd like to think of it. There's one in older individuals who have chronic sun exposure, and you get it on the top of their head or neck. The other population is patients with breast cancer who have had radiation. This particular angiosarcoma will have MYC amplification. And then the third angiosarcoma is also kind of your breast cancer patients who had an axillary dissection and they have chronic lymphedema, or just patients with chronic lymphedema in general have a higher risk of angiosarcoma. Okay. Notochordal tumors. These are tumors derived from or showing notochordal differentiation, and that includes staining with brachyury, cytokeratin, EMA, and S100. So benign or variable S100. So benign notochordal tumors, these are, as the name implies, benign. They're incidentally found, they're on the axial skeleton, the skull base, vertebral bodies, or sacrum, and they're solid sheets of adipocyte-like vacuolated cells, as you can see here. And they have these bland nuclei, no mites, sometimes cystic areas, but unlike a chordoma, there should be no extracellular myxoid matrix, tumor vasculature, fibrous septae, or lobular architecture. But since we talk about chordoma, let us go to chordoma. This is malignant, also in the axial skeleton, usually between the skull base, especially the clivus, vertebra, and sacrum. There's large epithelioid cells with eosinophilic to clear cytoplasm, but in this case, it's separated into lobules by fibrous septae. Some cells have this bubbly phycilliferous cytoplasm. Phycilliferous is so much funner to say than bubbly. Phycilliferous cytoplasm. It's arranged in cords and nests embedded in abundant myxoid matrix. It can have variable pleomorphism and mitotic activity. It expresses brachyury and cytokeratin. It has intermediate aggressiveness but can de-differentiate. And poorly differentiated chordoma, you'll have these cohesive nests of epithelioid cells with abundant eosinophilic cytoplasm, scattered signet ring-like cells, often rhabdoid areas. You'll have loss of SMARCB1, or it's also known as INI1 expression. Okay, miscellaneous tumors. Before we begin on miscellaneous tumors, let's go back to just do a quick, very quick overview of bone tumors again. Normal bone, we talked about woven, immature, lamellar matrix, or lamellar bone, which is mature. Lamellar bone, you'll have your cortical compact bone based on your architecture, with the Haversian canals, and the trabecular bone. Osteogenic tumors, osteoid osteoma, less than or equal to 2 centimeters. Osteoblastoma, greater than or equal to 2 centimeters. Both have FOS gene rearrangement. Osteoblastomas will be in the posterior spine. Osteomas, these are found on the face or jaw. They're more mature looking than your osteoblastoma or osteoid osteoma, but all of them are benign. If you see multiple osteomas, think about Gardner syndrome. Osteosarcoma, you can have high-grade central osteosarcoma. You can have Low-grade central osteosarcoma. This one has the MDM2 amplification. Telangiectatic osteosarcoma, think about your differential of ABC, which has your USP6 molecular finding. PAR osteosarcoma has the best prognosis. It's on top of the bone, has the MDM2 amplification. You can have cartilage. Periosteosarcoma, predominantly chondroblastic and arising from the bone surface, usually under the periosteum. You can have small cell osteosarcoma and high-grade surface osteosarcoma. Chondroblastic tumors include your benign osteochondroma, your enchondroma, which is a hyaline cartilage neoplasm in the short tubular bones of the hands. You can have frequent IDH1 and IDH2 mutations, and if you have multiple, think about Allier and Maffucci. You can have your Nora lesion or your bizarre osteochondromatous proliferation, also in the small bones of the hands and feet. Synoviochondromatosis, you see multiple hyaline cartilage nodules. Chondromyxoid fibroma, look for those chondroid and stellate cells embedded in a chondroid to myxoid matrix. Oftentimes in the long bones near the knee. Chondroblastoma, look for that chicken wire calcifications. It has an H3.3 K36M substitution similar to of your giant cell tumor of the bone. You can have giant cells. Subungual exostosis, it's a benign osteocartilaginous surface in the distal pharyngeal bone underneath the nail bed, most often the big toe. Chondrosarcoma, if it's in the arms or legs and grade 1, you call it atypical cartilaginous tumor. Otherwise, if it's in the axial skeleton, call it chondrosarcoma grade 1. Look for that cartilage kind of enveloping your existing bone. Chondrosarcoma grade 2 and 3. Dedifferentiated chondrosarcoma. Mesenchymal chondrosarcoma, you'll also, and it's similar to your dedifferentiated where you have like a kind of sort of like a biphasic. Mesenchymal, you'll have your hyaline cartilage as well as your undifferentiated component with, kind of reminds you of like a small round blue cell region. And molecularly has the Hay1 NCOA2. Your clear cell chondrosarcoma, clear cells, distinct cell membranes, not that much cellular atypia, frequently in the epiphysis, particularly the femoral head. Periosteochondrosarcoma, cartilaginous tumors on the surface of the bone. You should have invasion of the underlying bone, or it's got to be greater than 5 centimeters. Otherwise, you want to think about periosteochondroma. Hematopoietic neoplasms, think about your plasma cell myeloma or plasmacytoma if solitary. Think about leukemia and lymphoma for your small round blue cell differential. Consider sending for flow. Consider at least CD45, TDT, and or CD34 and CD138. Your histiocytic lesions, Langerhans cell histiocytosis. Get your S100, CD1A, Langerin. You'll see a lot of eosinophils. You'll see those characteristic grooved or folded nuclei. Your Erdheim-Chester disease, you'll have these foamy, lipid-laden histiocytes along with Teuton giant cells. Think about your the foamy histiocytes will stain with CD68, 163, 14. Rosai-Dorfman, look for your emperipoiesis. And then osteoclastic giant cell rich tumor differentials. Think about your non-ossifying fibromas. You have the store-form proliferation of plump spindle cells with intermingled giant cells, KRAS or FGFR1 mutations. ABCs or aneurysmal bone cysts, multiloculated blood-filled cysts, often in the metaphysis of long bones, most common in kids. You shouldn't see any atypia. Then you might want to think about telangiectatic osteosarcoma. Giant cell tumor of bone, you'll see this large osteoclast with more than 50 nuclei together with a mononuclear neoplastic component. You have that H3.3 gene mutation similar to the chondroblastoma, and these can become malignant. You can also have chondroblastoma, some osteosarcomas, and Paget's. Fibrogenic tumors include your desmoplastic fibroma, kind of resembles your desmoid type fibromatosis. There is nuclear beta-catenin in a subset. It has that infiltrated growth, most common in the mandible of children, and you've got to exclude low-grade central osteosarcoma and fibrous dysplasia. Fibrosarcoma, diagnosis of exclusion, look for your herringbone. Vascular lesions, when in doubt, get your ERG, CD31, CD34, Fly1, and factor 8. Hemangiomas, epithelioid hemangiomas, which should have eosinophils. Epithelioid hemangioendothelioma, look for your blister cells. You can have cells with intracytoplasmic lumina with red blood cells. And it's defined by WWTR1, CAMTA1 fusion, and angiosarcoma as well. We talked about notochordal tumors. Those will stain with brachyury, cytokeratin EMA, and variable S100. You have your benign notochordal tumor. Unlike your chordoma, there won't be extracellular myxoid matrix, tumor vasculature, fibrous septate, or lobular architecture. And chordoma, you have that phycoliferous cells are separated into lobules by fibrous septae. You'll have myxoid matrix. Okay, and then miscellaneous tumors, your simple bone cysts, these are benign, intramedullary, usually unilocular. These are simple cysts lacking a true lining with a thin wall of fibrous tissue. You'll often see fibrin deposition within the cyst, which can calcify. Fibrous dysplasia, kind of from low power, look like Chinese characters. These are benign, often medullary in the craniofacial bones or femur. They can be monoostotic or polyostotic. You'll have these irregular, curvilinear woven bone without conspicuous osteoblastic rimming. And you'll see fibrous tissue composed of bland fibroblastic cells. These are GNAS activating missense mutations. And then for fibrous dysplasia, you want to think about Mazabrots, which is fibrous dysplasia and intramuscular myxomas, as well as McCune-Albright, which is fibrous dysplasias, endocrinopathies, and Kapff-Allee macules. Osteofibrous dysplasia, this is benign almost exclusively in the tibia or fibula anterior cortex during childhood. You'll have woven bone with prominent osteoblastic rimming with intervening bland fibrous tissue. The cytokeratin highlights scattered single cells. And then if cytokeratin highlights clusters of cells, consider osteofibrous dysplasia like adamantinoma. Lipoma, hibernoma, these are benign. Lipoma, you'll see mature appearing adipocytes with a single large vacuole that displaces the nucleus. And then hibernoma is composed of brown fat with large cells with eosinophilic cytoplasm with numerous small clear vacuoles and a central nucleus. One of my favorite entities. Chondromesenchymal hamartoma of chest wall. These are benign. They're a well-circumscribed mass arising from the rib present at birth. And you'll see it's composed of nodules of hyaline cartilage with blood-filled cystic spaces, reactive bone, bland spindle cells, and osteoclast-like giant cells. Leiomyosarcoma. These are malignant, often lower extremity near the knee. You'll see intersecting fascicles of uniform cells with eosinophilic fibrillar cytoplasm. The nuclei will look cigar-like, and even though it has a lot of pleomorphism, and if you're unsure if it's undifferentiated pleomorphic sarcoma or leiomyosarcoma, you can order an SMA Desmond and or H-Cal Desmond. Of note, leiomyosarcomas, if you have one of the skin, it's now called an atypical intradermal smooth muscle tumor because it has really good prognosis. If you have leiomyosarcomas in the uterus or in the retroperitoneum, there's a higher threshold for having mites. However, anywhere else elsewhere that's not in the retroperitoneum, that's not in the uterus, and we're not talking about the skin, you have a very low threshold. If there's even one mite, you want to be very suspicious and be suspicious for leiomyosarcoma. All right, Ewing sarcoma. This is malignant, most common in the diaphysis of long bones. They'll have this onion skinning appearance on radiology. It's most common in children and young adults. It's part of your small round blue cell. And IHC, CD99 will be diffuse membranous. It is not specific though. NKX 2.2 is much more specific, and you can do FLY1 or ERG based on their fusions. Molecularly, you'll have your EWSR1 fusion. The most common one is with FLY1, and that's where it'll stain with FLY1, or EWSR1 ERG. In that case, it'll stain with ERG. Adamantinoma, this is locally aggressive to malignant, often youngish adults. It's located in the cortex of anterior tibia or fibula. It's biphasic, and it can have a variety of morphologic patterns, but you'll see this epithelial component within a bland osteofibrous component. The different subtypes includes your classic adamantinoma. You'll see an obvious epithelial element in fibroosseous stroma. Osteofibrous dysplasia like adamantinoma, these are inconspicuous epithelial cells. You can see clusters on cytokeratin IHC, and it's primarily osteofibrous lesion. And dedifferentiated adamantinoma, epithelial component progressed to high-grade sarcoma. And then your other small round blue cell sarcomas include your kind of genetically defined or molecularly defined chick rearranged sarcoma. You'll oftentimes have the chick dux4 gene fusion. It's common in young adults. CD99 will be variable, frequent WT1 ERG and calretinin staining. It has worse prognosis than Ewing's. Sarcoma with B-core genetic alterations. This is also your small round blue cell. And you'll have B-core gene fusion or B-core internal tandem duplications. IHC will be positive for B-core, SATB2, TLE1, and cyclin D1. And survival is similar to Ewing's. And then you can have your round cell sarcoma with EWSR1 non-ETS fusions, Ewing-like sarcoma. Undifferentiated pleomorphic sarcoma, this is a diagnosis of exclusion. It's often in the long tubular bones near the knee of adults, often older. You don't know where it arises from. There's no identifiable line of differentiation. It has spindle to epithelioid cells with marked pleomorphism and various growth patterns. They can sometimes even have giant cells. There should be no osteoid or cartilage production, because in that case, you kind of know where the line of differentiation is. At least do an S100, SMA, Desmond, CKAE1, AE3. If you see extensive AE1, AE3 cytokeratin, consider metastatic carcinoma. If you see focal staining with one muscle marker like SMA, but if more markers are also positive, Desmond, consider leiomyosarcoma. SATB2 can be positive. H3.3 expression suggests derived from giant cell tumor of bone. And IDH1-2 mutations can suggest dedifferentiated chondrosarcoma. And then here are your genetic alterations for your boards. And syndromic. So, thank you so much for listening to this. If you went through with me on this journey of bone tumors, let's give a huge shout out to Dr. Schaberg, and for you for for Dr. Schaberg for writing all of this, and for you for listening and just kind of rereading all of this. So I promise, last run of things we're going to talk about. Bone tumors, normal bone, immature is woven, mature is lamellar. You have your lamellar, you have your architecture differences, cortical, compact bone, and trabecular, cancellous bone. Osteogenic tumors, benign osteoid osteoma, osteoblastoma. Both have FOS gene rearrangements. Osteoma, think about Gardner syndrome. Conventional osteosarcoma, you can have high grade, you can have low grade. This is MDM2 amplification. Telangiectatic, think about aneurysmal bone cyst. If you're unsure, get that USP6 study. Parosteosarcoma, the best prognosis amongst osteosarcomas, and has MDM2 amplifications. Periosteosarcoma has chondroblastic predominantly. You can have small cell osteosarcoma, high-grade surface osteosarcoma. Chondroblastic tumors include osteochondromas. In chondromas, if you have multiple, think about Ollier's disease and Maffucci syndrome. bizarre osteochondromatous proliferation in the small bones of the hands and feet, synovial chondromatosis, multiple hyaline cartilage nodules, chondromyxoid fibroma, chondroblastoma, look for that chicken wire-like calcification, subungual exostosis, chondrosarcoma, think about grade 1, based on location, if it's in the arms or legs, a typical cartilaginous tumor. Dedifferentiated chondrosarcoma, mesenchymal chondrosarcoma, biphasic, has that Hay1 NCO-A2, clear cell chondrosarcoma, periosteochondrosarcoma, which will either invade the underlying bone or be greater than 5 centimeters. Otherwise, think about periosteochondroma. Think about your hematopoietic neoplasms, like your plasma cell neoplasms, leukemia and lymphoma. Get your CD45, TDT, and or CD34, as well as CD138. Langerhans cell histiocytosis, get that CD1A Langerin. Erdheim-Chester, also a histiocytic one, disease. You can have variable amounts of Tutin giant cells with foamy lipid-laden histiocytes. Rosai-Dorfman, look for that in peripoiesis. S100 positive histiocytes. Your osteoclastic giant cell rich tumors, your non-ossifying fibromas, which are really common, relatively storiform proliferation of plump spindled cells with intermingled giant cells. Your ABC, get that USP6 gene arrangement if you're not sure if it's telangiectatic osteosarcoma. Giant cell tumor of bone has that H3.3 gene mutation. Fibrogenic tumors, desmoplastic fibroma, kind of looks like your desmoid type fibromatosis, but it's in the mandible, and you must exclude low-grade central osteosarcoma and fibrous dysplasia. Fibrosarcoma, look for that herringbone. It's a diagnosis of exclusion. Vascular lesions, think about whether it's circumscribed or not. You can have your hemangioma, epithelioid hemangioma, which will stain positive with keratins and have a lot of EOs. Epithelioid hemangioendothelioma, think about that website, WWTR1, CAMTA1 fusion. It's going to have those blister cells and a myxohyaline stroma. Angiosarcoma, think about your HHV8 rule out capices, and think about what type of angiosarcoma this patient has, if it's MYC amplified or not. Notochordal tumors, benign notochordal tumor, and then chordoma. In contrast to chordoma, benign notochordal will not have extracellular myxoid matrix, tumor vasculature, fibroseptate, or lobular architecture. And then miscellaneous tumors, your simple bone cyst, fibrous dysplasia. It has a GNAS activating missense mutation. Both Mazabrod and McCune-Albright have GNAS. Osteofibrous dysplasia, you'll see woven bone with prominent osteoblastic rimming with intervening bland fibrous tissue. Lipoma hibernoma, chondromesenchymal hamartoma of chest wall that's present at birth on the ribs. Leiomyosarcoma, Ewing sarcoma, get that CD99 diffuse membranous NKX 2.2, Fly1 ERG, depending on their diffusion. Adamantinoma, located in the cortex of anterior tibia or fibula. It's biphasic with an epithelial component and a bland osteofibrous component. You can get classic osteofibrous dysplasia like adamantinoma and dedifferentiated adamantinoma. Your other small round blue cell sarcomas, including your Chick rearranged, worse than Ewing's, sarcoma with B-core genetic alterations, round cell sarcoma with EWSR1 non-ETS fusions, and then your UPS, no identifiable line of differentiation, diagnosis of exclusion, should not see osteoid or cartilage production. All right, thank you so much for watching. We'll see you next time on Pathagonia. Bye.